GI surgery in DMC.
Yes, sir, let's begin.
So, a very good evening. Okay. A very good evening and a warm welcome to the 11th academic webinar of TUGSS Endoscopy. Now, today's session is very interesting for all the surgeons as we would be entering a new space, which is referred to as the third space, and learn about a procedure which is done in this particular space. So, it's my pleasure to welcome all of you to this session where we are going to focus exclusively on the procedure of peroral endoscopic myotomy or POEM as it is commonly referred to as. Now, as a revolutionary technique for treating achalasia and even other esophageal motility disorders, POEM has actually transformed the scope of minimal access surgery. Today, led by an esteemed panel of experts in this field, this webinar will discuss about the intricacies of POEM, highlighting its benefits, patient selection criteria, procedural steps, and about the post-operative care of these patients. So whether you are a surgeon or a gastroenterologist seeking to expand your understanding about this procedure, now let us all together embark on this journey of POEM and its impact on enhancing the patient's quality of life. Now, as always, we will be having a lecture followed by a panel discussion and a Q&A session. And I request all of you to please post your queries and comments in the chat box and we will put them forth to the experts on your behalf. So to set the ball rolling, I would now request Dr. Parth to kindly introduce our panel of experts and the guest speakers. Dr. Parth, kindly go ahead.
Thank you, Dr. Balla. I would first like to invite our first panelist for today's guest lecture, who is Professor Satpal Singh Vir. Sir is currently the professor and head of Department of Gastroenterology Surgery at the Anand Medical College and Hospital in Ludhiana. He has done his MCH in Gastroenterology Surgery from GB Pant Hospital in 2002. Sir is a member of various international societies like IHBPA, SAGES, ASI, ISDE, and ISLCR. Welcome, sir. Next, I would like to invite Dr. Vikas Singla, sir. Sir is the director and head of gastroenterology and at Max Super Speciality Hospital, Saket, New Delhi. His area of interest include third space endoscopy, therapeutic endoscopic ultrasound, and so on. With over 18 years of experience in endoscopic surgery, we welcome Dr. Vikas Singla. And our third panelist for the day is Dr. Harpal Singh. He is a senior consultant at AGI, the Gastro City at Ludhiana in Punjab in India. And he has done his senior residency from AIG Hospital in 2013. He has more than 10 years of experience in endoscopic and laparoscopic surgery. We are grateful to all these panelists to find time for this on this weekend and join us on today's webinar. And we welcome you all for this academic feast. Now I would like to invite and introduce to you our speaker for the day, Dr. Nirmaljeet Singh Malhi. Sir has done his DM Gastroenterology, FACG, FASGE. He is currently the chairman and chief of gastroenterology at AGI, the Gastro City in Ludhiana. He is the founder and current secretary of the Punjab chapter of ISG, that is the Indian Society of Gastroenterology. He has done pioneering work in the field of advanced endoscopy and is instrumental in introducing endoscopic surgery and cholangioscopy in that region of Punjab and surrounding states. It is an honor to have such stalwarts for today's meeting, and we thank you all for joining. I would request everyone else apart from the speaker to mute their mics, and now I would hand over to our speaker for the day, Dr. Malhi. So you can now share your screen.
Okay. First of all, a very good evening to all of you. I believe my slides are now visible and my voice is clearly audible to you. Am I right?
Yes, sir.
You're able to see full screen of my slides?
Yes, we can see. Dr. Malli, you are visible.
Okay.
You can see the slides.
Yes, perfectly fine. So thank you, Parath, for the kind introduction. And good evening to all of you, all the members who joined from TUGSS Endoscopy. My special thanks to Bhavneet Balla for giving me the opportunity to be the main speaker for a topic of third space endoscopy. and with a special emphasis on poem and its applications, and with an elite panel of panelists who have actually sizable experience in doing poem as well as in laparoscopic Achalasia myotomy. So my presentation is going to be nearly a 35-minute presentation where I'm going to take you or embark on a journey from the very basic concept of how this third space has evolved, touching a little about the historical perspective, then the scope and applications of poem in today's era, procedural details, and then I'll take you through the results and the adverse effects. As all of us are aware, and we know about the anatomy of a viscus, here we talk about esophagus. Like any other hollow viscus, we have 4 layers from mucosa, submucosa, muscle layer, and we have an adventitia in place of serosa. When we talk about spaces, the first space is always the lumen, the GI lumen, where we people daily during our endoscopies we go. The second space is beyond the wall of the hollow viscus. So that is either a mediastinum if we talk about thorax, or peritoneum if we talk about abdomen. And any potential space between the lumen, which is first space, and the abluminal aspect, which is outside the wall, is the third space. And this third space is submucosa. So submucosa, if we talk about in normal humans, is barely 1 millimeter thick. But this is a potentially distensible space. So you put fluid, you can distend it to be 1 centimeter and beyond. And this is what the whole advantage of this point has been taken in performing all the third space procedures, specifically poem. And this is a line diagram which illustrates the same fact. We have mucosa. From mucosa, we inject fluid into the submucosa to raise a bleb. Over that, we give an incision, and by this, we gain entrance into the submucosa. We do a submucosal dissection to create a long tunnel. Then we keep a 2 centimeter of muscularis propria intact, and beyond that, then we do a myotomy from the mucosal aspect till the desired length, which is normally 2 centimeters beyond the lower limit of LES when we talk about poem. And then we close this mucosa over the intact musculature, giving it the stability of an air or a watertight closure, which we're able to attain. So thereby, with this concept, on one side, we're able to perform surgery with an endoscopic means, where the root is endoscopy, the accessories are all endoscopic, and the principle is simple. You are taking advantage of submucosa, doing a dissection, keeping a small part of muscularis propria intact, and then closing, giving it a strong bonding, and that's why it makes it minimally invasive and extraordinarily safe. And the credit for all this, among so many luminaries who have contributed hugely to this approach, the 2 standout names which come to us, one is Pankaj J. Pasricha, the Indian who's from All India Institute, New Delhi graduate, but now working in Johns Hopkins. It was a seminal work from Dr. Pasricha in 2007 in porcine, basically in pigs, which showed us that submucosal endoscopic myotomy is possible, is feasible, and is safe. And Professor Inoue, who's a cardiothoracic surgeon, actually went on to do the first human cases. And the first publication came in 2010 in Endoscopy of human cases of performance of poem, technical feasibility. And thereby, just from 2010, in just a period of over 12 to 13 years, poem has phenomenally grown in stature. And now there is no doubt, I think, in mind, many of us, that possibly this is the treatment of choice for achalasia and many more esophageal dysmotility disorders. Not only poem, there has been a rapid expansion in the armamentarium of what we call the third space procedures, or the submucosal tunneling procedures, where we can now remove the subepithelial tumors by a technique called submucosal tunneling and endoscopic resection, or STIR. For refractory gastroparesis, we have a gastric poem. For Zinkers, we have a Z poem. For Hirschsprung, we have per rectal endoscopic myotomy. So this spectrum is growing by each passing year, I would say. And I think we all are a witness to history in the making. But I'll be keeping my talk focused more on peroral endoscopic myotomy, or which is nicknamed as POEM. And the classical indication for POEM undoubtedly is achalasia cardia. And achalasia, I think we all have come in our practice, which is something we do see routinely. People come with a long history, generally months to even a couple of years. And the commonest symptom is dysphagia. And dysphagia along with regurgitation of food. And maybe a third of patients, they come with chest pain and then varying degree of weight loss depending upon the duration and severity of symptoms. And this is a score which all of us follow in our clinical practice for diagnosing achalasia cardia, severity, and then also to determine the therapeutic effect, even post-pneumatic dilatation or people who had received Hellas myotomy in the past. And now in POEM, on every visit, we look at their Eckert score. And once Eckert score is less than 3, that means a clinical success or technical success of the procedure. A word about achalasia before I move on to POEM. Achalasia, again, the diagnosis rests on, there was age-old modality of esophography, which previously was barium swallow. But now many times we do a gastrograph in swallow also, looking at the esophageal size, then the narrowing of the G junction, and more so in people with sigmoid esophagus. But the gold standard for diagnosis of all dysmotility disorders, including achalasia, is esophageal manometry, where we not only diagnose, but subclassify achalasia into type 1, 2, and 3, followed by endoscopy, which again is an important part of diagnosis, and at the same time excluding any mechanical obstruction or, more importantly, pseudoachalasia. And this, all of us are aware during our residencies days, we have been all seeing the barium swallow examinations, dilated esophagus, some early tertiary contractions, a bird beak or tightening of the LES. This is early to an intermediate stage of achalasia. More advanced stages, you have gross dilatation. If dilatation is beyond 6 centimeters, we label it as a sigmoid esophagus. There's a fluid level, there's an axis deviation, and an extreme degree of tightening. So this is sigmoid or an advanced achalasia. And this is classical, which we do in all our patients before diagnosis, and then once we subject them to POEM on their follow-up. So esophageal manometry, I think we had a great session last time on manometry itself. And achalasia is basically 2 criteria which label achalasia. You have an elevated LES pressure, which fail to decrease in response to swallow. And secondly, there is an aperistalsis in the esophageal body. So these are the LES pressures which are consistently high. If there's a complete aperistalsis, we call it as type 1. If 20% of the swallows, they show pan-esophageal pressurization, that's type 2. And if in response to swallow, 20% have a premature or spastic contraction, it's type 3. So type 1 and type 2 are non-spastic achalasia. Type 3 is spastic. And there is a variability in our approach of POEM in non-spastic versus spastic achalasia. Talking about endoscopy, this has always been the main pillar for diagnosis. But I'll tell you what I've found in our experiences, achalasia, ironically, in early stages, is also one of the commonly missed entity on endoscopy. The reason is in early stages, you do not get enough dilatation. And the only sign is pooling of saliva inside the esophagus, which you start the moment you go beyond UES, even in upper esophagus, you start finding salivary pooling and there is coating of saliva along the walls. That means aperistalsis in this part, which doesn't allow even saliva to push down. Later stages, you have the food residue, there's a coating of food, liquid and solid contents, multiple tertiary contractions, and then a very tight LES, which needs pressure by the scope and little maneuvering to go across it. So in this stage, missing an endoscopy is not, one is able to pick up easily, but only in earlier stages where one needs to be more cautious in people coming with maybe intermittent dysphagia, a positive saliva sign, and maybe early tertiary contractions could be the first sign of achalasia on endoscopy. When we talk about, after this introduction of achalasia, the indications of POEM, I think all three subtypes, type 1, 2, and 3, treatment naive as well as treatment experienced patients, patients who have received pneumatic dilatation and recurrence or a post-Hellas myotomy, they all can be tackled very well now with POEM. And all hypertensive esophageal motor disorders like diffuse esophageal spasm or a jackhammer esophagus. The main contraindications stay out to be a severe cardiopulmonary disease where you cannot give general anesthesia, severe thrombocytopenia, cirrhosis with portal hypertension, and where people have received radiation or extensive esophageal mucosal resection or ablation, so that the submucosa is practically ablated. So in this case, submucosal tunneling or dissection is impossible, and this automatically qualifies as a contraindication to POEM. Pre-procedure, we maintain people on a liquid diet, generally a clear liquid diet, at least a day prior to procedure. An evening prior, we start them on IV antibiotics. Generally, piperacillin tazobactam is our first choice, along with intravenous fluconazole. Procedure is done under general anesthesia, in supine posture, and patient being intubated. And the most important thing is we always use carbon dioxide gas. It is never done under air because air can have real catastrophic consequences. So it has to be CO2, and that too with a ultra low flow tubing. So it will be a very low flow of CO2 coming all through the procedure. And when we talk about the procedural equipment, this is a Olympus 190. This is a standard scope we all use for our procedures with an outer diameter of 9.9 millimeters, and the channel diameter is 2.8 with a distal transparent attachment or a cap which is applied to the scope. This is mandatory for all third space procedures, including POEM, because this gives us better visibility, even helps in dissection, and also in hemostasis. And we use carbon dioxide insufflator, and the common cautery we use is basically YO 300 electrosurgical unit. The most important thing, we have to first make a mucosal bleb over which we give a mucosal incision. So this is the injector we use, which is generally is a 23G, and methylene blue in a diluted form in saline is the one we commonly use for injection. There are two types of electrosurgical knives, one which comes from Olympus, which is called as triangular tip knife for dissection. We use all the way from mucosotomy to tunneling to even performing myotomy. And the other which comes from Urbe, it is called the hybrid knife, the T-tip type. And there is another instrument called co-grasper, which is used for hemostasis of larger vessels. And these are hemoclips for the mucosal closure. And this is how, in our center, the POEM cart looks like. We have a 190 Olympus scope HQ with a distal transparent attachment cap, diluted methylene blue with an injector, triangular tip knife, co-grasper, and then we have the hemostatic clips. What about the steps of the procedure? This is basically 4 steps. The first is raising a bleb and then giving an incision over it, which is mucosotomy. Then we do a submucosal dissection with the electrosurgical knife all the way beyond G junction, going at least 3 to 4 centimeters to gastric cardia. This is called submucosal tunneling. Then keeping 2 centimeters of muscularis propria intact, we start doing a myotomy till almost 2 centimeters beyond the lower limit of LES. So this is the whole myotomy which has been done. And then the closure of the mucosal defect with the help of hemostatic clips. And these are the photographs of how the mucosotomy, the tunneling, and then myotomy and closure. So this is a short 3-minute video which will show the different steps of POEM. I'll stop here. So one thing to note is this is the transparent cap I was talking about. Here is the anterior wall of the esophagus. patient is in supine posture. This is the posterior wall, and here is our spine. Spine generally comes at 7 o'clock position. And normally we go for myotomy for the posterior generally at 5 o'clock axis. So here what we are using is the hybrid knife. This is when we started doing POEM at our center. This is a 2016 video. We were in fact the first center in entire Punjab to start POEM and third space procedures. And we've gone a long way since then. So this is the step of mucosotomy. So we have made a bleb. There is a methylene blue in the submucosa. So we are giving an incision, and this is the submucosa, how it looks like once we give this incision. And after giving this incision, which is around 1.5 to 2 centimeters, we do a little dissection on the sides so that the cap is gently able to glide into the submucosa. So this is now the cap has gone into the submucosa. And then with the same knife, here we're using the hybrid knife. So by fiber, layer by layer, we go on dissecting the submucosal fibers, which are just like a gauze. It's a very gauzy appearance. And the mode we are using here is a spray coagulation, which we were using at that point of time in 2016. And we go all the way deep into the cardia. This is the view of the gastric cardia. This is generally the tighter portion, the LES. Mucosa is right at the top. And this is now the circular muscle fibers in the lower esophagus. So standard tunnel which we make, so you see mucosa here, muscle all down here. So standard tunnel is around 12 to 14 centimeters long. And once we make a tunnel, then the next step stays out to be doing a myotomy. The same knife is being used to cut the muscle. So these are thick circular fibers we cut. At that point of time when we started POEM, the dictum was to do a selective circular myotomy. So that's why in video we'll demonstrate. So this is all the thick circular fibers, and these are the thin longitudinal fibers. So now this is a plane, which is an intermuscular plane. And here we are actually cutting the circular fiber. So we basically take our knife, hook it inside between the two, lift it a little bit, give a forced coagulation, which is the mode we use, and then we cut it. So it's a very, very controlled way of doing a myotomy, and we go all the way beyond LES. And this is now, here's a full thickness. And these are how the cut ends post-myotomy they look like. So you have mucosa right at the top, cut ends of the muscle, no longitudinal layer, this is adventitia. And here they have the longitudinal fibers which were retained at that point of time. And then the whole closure is by applying hemostatic clips one after the other. And generally on average, we need 4 clips for complete closure of this 2 centimeter defect. And this is a complete water or a airtight closure of the defect. A post-procedure, after 24 hours, routinely we do a gastrographin esophagogram, basically to rule out a leakage from the mucosotomy site. We initiate liquid diet the same day, and generally most of the people are discharged on the next day evening. And then we follow up them at 1 week, and then at 1 month, 3, 6, 9, and 12 months. And generally do a manometry and endoscopy somewhere between 1 to 3 months to look at the therapeutic response. And Eckert score drop by 3 or total score less than 3 depicts clinical success. And once we talk about now the results, so there's now enough data which has come up in the last 12 years. These are studies I picked up, which are the largest number of patients. There's been a significant drop of Eckert score following the procedure. All studies, the mean Eckert score is, in fact, almost close to 1. And there's a follow-up data now available from 7, and now we have 10-year studies also. The clinical success consistently in all the studies, it stays even at 7 to 10 years is more than 90%, making it as efficacious as a Heller's myotomy is. And if you look at the adverse effect, they're absolutely comparable. Rather, in many of these studies, there was a non-statistical trend of a better safety with POEM compared to Heller's myotomy. So thereby, in just a 10 or a 12-year period, it has grown to those proportions where it is actually now becoming the first choice for people suffering from Achalasia cardia or other esophageal dysmotility disorders. And this is now the largest study where 10-year outcomes have come. This has come from the United States of America, from Dr. Stavros group, a big data of 610 patients. 50% had type 2 achalasia. The mean operating time is around 54 minutes. And the clinically significant adverse events were only 3.4%, and majority were tackled intra-procedural. So there were no deaths, no need for surgery, drains, or any radiological interventions. And the clinical success stays out to be beyond 90%, even at the longest possible follow-up available. One concern which was raised somewhere in the late 2017, 18, and 19 was the issue of reflux post-POEM. And even this study at that time looked at was around 20% of reflux symptoms more than a week. But when we compare the data available to us from POEM vis-a-vis laparoscopic Halley's myotomy, we have now 6 large studies. One of them is a randomized controlled trial, which was published in New England Journal of Medicine in 2019. Out of remaining 5, 2 are prospective and 3 are retrospective data. The clinical efficacy, absolutely nothing to differentiate between the two. The adverse effect profile, I again told you, a non-statistical benefit towards POEM when you compare to Halley's myotomy, wherein follow-up available. The only issue was reflux. When you compared with Heller's, where we are doing DAW fundoplication as a routine in those patients, when you compare, there was a trend towards higher reflux esophagitis in the POEM group. But mind you, this reflux, what we're talking about, was not the symptomatic reflux. This data which was shown was on 24-hour pH metry in these patients. And then there came a large 2018 systematic review with meta-analysis, which again showed that on pH metry close to 39%, they have evidence of reflux. Endoscopically, it's a 10% less. Symptomatic reflux was close to 15% in this meta-analysis. But then there was a lot of hue and cry. Voices were raised, and there came even an editorial endoscopy that reflux after POEM will POEM die an early death. So that was actually an endoscopy in 2019, but not to be. So then there was more introspection, looking at data, what we're talking about. A 40 or a 50% reflux we talk about, again, is pH studies. Endoscopy is much less, but symptomatic reflux is even in a much lesser proportion. And even people who had reflux post-POEM, in majority, it was mild, it was non-erosive or LA grade A, and it was PPI responsive. And severe reflux was encountered in an extreme minority. More importantly, once you followed these people who did have a reflux from 1 month to say 2 years, they had a higher reflux at 1 to 3 months, which tend to plateau around 6 months to 1 year. And then there was a decrease in reflux beyond 1 year. And at 2 years, the reflux episodes were very similar to people who had lap Halley's myotomy with DOR fundoplication, meaning thereby there is some adaptive mechanism to take place, which takes some time. So maybe doing a very early pH metry might be overestimating the reflux. The right time might be maybe doing somewhere at around 3 to 6 months. There was further introspection that there are certain technical aspects that need to be modified by which we can decrease why reflux happens post-POEM. In Halley's myotomy, the mechanism of reflux is we are actually obliterating or disrupting the extrinsic sphincter also, which is responsible as an anti-reflux, which is the phrenoesophageal ligament and the angle of His, which actually are nowhere disrupted in POEM. So POEM practically should have much lesser reflux compared to Halley's myotomy. So the reason they were found, initial myotomies were very liberal. People were not very sure how much the gastric myotomy needs to be done. So there was a fear that there should not be an early recurrence. So the gastric myotomies were in the length of 4 to 5 centimeters. So once gastric myotomies were limited to 2 centimeters or below, the reflux episodes in these people, they demonstrated a precipitous drop. And second was saving the sling fibers of LES. So once we do POEM, we do LES dissection. Now on the posterior approach, we are able to beautifully discern these oblique shaped fibers, which are called the sling fibers. And we take the direction of our myotomy towards the lesser curve. There's a special vessel which has been reported by Shinwa Tanaka from Japan. It's now labeled as Tanaka's vessel. That is a very consistently we find that vessel on posterior myotomy. That vessel comes generally at the end of the LES and junction of LES with cardia. To left of that, you find the oblique sling fibers, and on the right, you find the circular fibers. So if you dissect your right of that Tanaka's vessels, these fibers are going to be spared. And that is why studies in 2020 and beyond, the degree of reflux has been shown to be very, very low, very much comparable to Heller's myotomy. And let's suppose someone has a reflux which is really bothersome, which is what is LAC or D, or which is partially PPI responsive. We have endoscopic anti-reflux therapies for which there's a beautiful paper which has come this year in the month of April from Dr. Amit Madhyo's group in Mumbai, where in people who had a significant reflux, which is persisting beyond 1 year post-POEM, they subjected these people to endoscopic full-thickness plication by a device called GERD-X. GERD-X we do use in people for endoscopic management of GERD. It's a simple procedure which takes around anywhere between 20 to 30 minutes. And they have shown in 60 patients, 30 in one group and 30 in sham, there is a significant improvement in the 24-hour pH metry, decrease in PPI usage, and even the clinical GERD questionnaire. So now the guidelines are very correct. You need a posterior approach. You need to save the oblique fibers. You need to do a limited gastric myotomy. Your risk of reflux is going to be very minimal. And if that reflux is there, and that is really needs attention, endoscopic full thickness plication on follow-up could be the answer. What about people who have undergone Heller's myotomy in the past, and now they have a recurrence of symptoms, or they have failed Heller's myotomy? So POEM again is a very good answer for those patients. So this is again another systematic review and meta-analysis of 272 patients from 9 studies. In almost all, POEM could be successfully performed by a posterior approach, and there was significant resolution of symptoms and was found to be as safe and as effective as in Achalasia naive patients. And this is again one of our own videos. This is a post-lap Heller's patient had undergone 14 years back. Now he had come with a sigmoid esophagus. Posteriorly, there is no wrap. And this is what we look at the door fundoplication on endoscopy. It's almost a 270-degree wrap on anterior and the lateral aspect. The important thing is we have to always do a posterior POEM in such patients, because anteriorly a myotomy has already been performed and there'll be a lot of fibrosis. So the technique stays exactly the same. We go posteriorly at 5 o'clock, we raise that mucosal bleb, and with the electrosurgical knife, nowadays our preferred knife is generally the Olympus knife, which is called the triangular tip knife with J or jet function. So this is how this tip looks like. And we used forced coagulation as the primary mode for coagulation or cutting nowadays for POEM procedure. So again, doing a dissection just to gain entrance. And this same TT knife has now been used for dissection. And dissection is much faster with this knife. So here is now the muscle layer. Mucosa will be somewhere here. We actually dissect right at the muscle itself. So we're never able to see mucosa. So risk of mucosal incision or an accidental mucosotomy is almost negligible nowadays in experienced hands. And we do come across, in many of those post-Hellers, we do come across bigger vessels close to G junction. For this, we use this instrument, which is the co-grasper. We actually catch hold of. and you do use a mode which is called soft coagulation. And with this, you see the entire vessel is coagulated. And even intra-procedural bleeding is now not an issue with the help of a different set of accessories we have. And this is this patient. You're seeing some axis deviation because for a sigmoid esophagus, again, we've done a long tunneling followed by long myotomy. So we have, again, very good experience, even people with recurrence of dysphagia post-Hellas myotomy. Complications are actually serious complications are negligible in centers we have good experience. Accidental mucosotomy is only in early part of your learning curve, or where there's a substantial submucosal fibrosis. There you need to go a little slow, and you should have liberal fluid supplementation to keep mucosa away. Major bleeding and perforations are exactly uncommon. Reflux I touched about. Subcutaneous emphysema and pneumomediastinum and pneumoperitoneum we see in around 10% of procedure, but they are self-limiting and nothing much needs to be done. Bleeding could still be an issue in some of our patients. There's a clean dissection going on right at G junction, nothing visible, but then suddenly there was this tiny vessel which was not visualized. It was one of a penetrating vessel coming from the muscle plane at G junction. So initially, we generally try to control it. We use water jet and try to do it with the TT knife itself. But if the flow is more, at times we are not able to control it, as the vessel here is actually a much bigger vessel which is coming from this. And then we have to use co-grasper, and then we go right at this is the muscle. So junction of the submucosa muscle, we actually catch hold of this, then apply our soft coagulation at 80 wattage, which is a general setting we use for co-grasper, and then the whole vessel is coagulated. Lastly, few things which are the new adaptations, or I would say evolutions in the technique of POEM over the last 3 to 4 years, which I think surgeons will be really interested. Which approach to adopt for POEM, anterior versus posterior? Anterior is 2 o'clock when patient is in supine posture. Posterior is 5 o'clock. Very similar, there's nothing to choose. But only thing is in posterior, what we have found is, because posterior is at 5 o'clock and our accessories come from scope at 7 o'clock, the manipulation of accessories is easier in posterior approach. You have better maneuverability, and more so in post-Hellas myotomy, you'll be able to do only a posterior, not an anterior approach. So my preference, of course, will be posterior will be the preferred, but it's one's own, I think very little to choose between the two. Myotomy thickness, selective or a full thickness. Dr. Inoue initially was circular, selective only, and full thickness at G junction. But nowadays, enough data that possibly full thickness, you are able to save time, and there's no increase of extra reflux. So possibly full thickness all the way is going to be the answer. Esophageal myotomy, short or standard, and what should be the length of gastric myotomy? So for this, we have now at least 5 studies. We have looked at this thing. This is the largest study, which has come again from China. When we call it a standard POEM, means 7 to 8 centimeters of esophageal myotomy and 2 centimeters of gastric. That means roughly 10 centimeters. Shorter POEM, you do just 4 centimeters of esophageal and 2. That means 6 centimeters of total myotomy. The results were exactly the same. So even a shorter myotomy gives you as good result as a long length or a standard. This is for type 1 and type 2 achalasia. This is not for type 3 achalasia. There anyhow we have to do a long myotomy. With shorter, the advantage was there is significant reduction in total procedure time, which was they were saving approximately on an average 15 minutes. And this is what now the latest guidelines, which came in 2022, type 1 and type 2 achalasia, a shorter myotomy can be favored, but type 3, you have to divide till the upper limit of the spastic segment. And that invariably means a long myotomy. So short is here 3 to 4. Here you'll end up doing an 8 to 10 centimeter of esophageal myotomy. Gastric is 2 centimeters is a cutoff. The longer you go, more reflux you're likely to give to your patients. And it is full thickness which is favored over the selective circular. Before I end my presentation, this is our beginning in 2016 with the help of Dr. Mohan Ramchandani from AIG Hyderabad. So Mohan was a great help for initial cases. We did under his guidance. And now we are almost completing 200 POEM cases in our center. Almost 2/3 of our patients have actually type 2 achalasia, roughly 1 hour of procedure time, which we normally now take. Bigger complications we haven't encountered, and our clinical success is very similar to which is the worldwide data. So, ladies and gentlemen, just to summarize, third space endoscopy and POEM have actually been a game changer. It's been a trailblazer. It's been a revolutionary step, I would say, which is a true amalgamation of art with science, endoscopy with surgery. And this is which has put the interventional gastroenterologist on a level playing turf or a common platform with the minimal access surgeons. The clinical benefits have been profound. We have enough short, mid, and long-term data showing its efficacy and safety. And this is now going to be a gateway to many more interventions, as I've alluded to in one of my slides on third space procedures. Thank you, and thank you so very much.
Thank you, Dr. Malhi, for that excellent talk. It was entirely very comprehensive. You have adequately covered almost all the aspects of this procedure. So the house is now open for discussion with our team of expert panelists. So any comments from any of the panelists? Dr. Vikas, we can start with you.
Yeah, Dr. Malhi, I think that was a wonderful presentation, and Dr. Malhi has covered most of the aspects, technique, and the complication. And regarding technique, I think POEM seems to be a difficult procedure, but I think it's easier to learn. So if you compare between the other procedure like ERCP, ESD, or the US, I think learning curve for the POEM is smaller one, and it can be easily mastered, provided you have a mentor to learn.
Totally agree.
Right. Dr. Satpal, the surgeon's
So
perspective.
Again, I think it was an excellent presentation by Dr. Malhi, because till now it was obviously the gold standard is LHM, laparoscopic hyaluronic myotomy LHM, but POEM is quite nicely picking up, and results are not inferior to surgery. I will say in certain group of patients like type 3, it is superior to surgery even. So I will say type 1, type 2, maybe more or less results are equal, except there's more of GERD. The problem still remains that it will require a steep learning curve. High volume centers can do, not easily available for everyone, because this is a specialized surgery that gastroenterologists which are not used to do it. This is basically a surgical procedure. And a surgeon who is doing a minimal invasive surgery, he's already a lot of experience in these surgeries. So he can learn easily. LHM is easy to learn rather than POEM procedure. And obviously, it is a very advantage in type 3, and we can tailor the procedure according to the esophageal pressure tomography. So that is, I think, big advantage in these patients. The patients which are not exactly type 1, type 2, unclassified, is very helpful in these patients. So I would like to ask one question, Dr. Malhi. Is it a diverticulum, epiphrenic diverticulum, is a contraindication for POEM?
First of all, I think that per se, even we haven't come across any patients where we had a achalasia and a epiphrenic diverticulum, but should not be a contraindication. One should be able to do it even in the setting of both of these things present in the same patient.
Dr. Malli, can I make a comment on that?
Yeah, right.
So if patient has a epiphrenic diverticulum, then we should do the manometry. Sometimes there can be a standalone diverticulum without achalasia cardia. In those patients, the symptom will be mainly of the regurgitation, and the dysphagia will be uncommon symptom. The food may accumulate in the diverticulum, and the patient may have regurgitation. But if it's achalasia with the pressure diverticulum, the main symptom will be dysphagia. So during the myotomy, you can cut the septum between the diverticulum and the esophagus, and the same septotomy can be continued on the esophageal wall across the LES. So I think barium and the manometry plays a very crucial role in deciding the treatment of these patients. Otherwise, I think isolated diverticulum is a rare situation. Mostly they are secondary to high pressure at the LES.
Right.
So they can be handled in the same situation. It's not a difficult thing. We can do the septotomy with the myotomy in the same setting.
Second, we have
Right.
like the surgeon know that it is very difficult to like navigate in sigmoid esophagus because its axis is deviated. How do you go directly towards the LES rather than going right or left? Is it some trick or what? How do you approach?
No. Sigmoid, Dr. Satpal, is always a challenge even for us. But in that, what we do is we always do a small dissection for 3 to 4 centimeters. We come back and then again come into the lumen. And we actually go a little slow in these patients because you have to be very sure how you have to go to the LES. It takes a longer time. But again, we've almost done close to now 4 sigmoid esophagus. It takes double the time to do a normal poem. But again, one has to go slow and one has to repeatedly come back to the esophageal lumen to see which direction we're making the tunnel.
Yeah, I think another challenge is the submucosal fibrosis. Once the patient has sigmoid esophagus, they have a lot of fluid which is accumulated in the esophagus, and we can see the mucosal ulceration, scarring, and the submucosal fibrosis. It technically also becomes very challenging to make a long tunnel in these patients. So you're right, you make a short myotomy in these patients. And regarding the direction, when we see the transverse fibers, we go perpendicular to the transverse muscular layer. That gives us a direction towards the G junction.
Right. So we tend to keep length of tunnel shorter in these people who have sigmoid esophagus, not like a 12 to 14. We might start much lower down. Maybe 8 to 10 centimeters tunnel would suffice in people with sigmoid.
Right. Dr. Harpal, would you like to come in before I take the questions from the house?
I think for poem, am I audible?
Yeah,
Yes,
please go ahead.
For poem, the person should be having a surgeon's mind as well as surgeon's hand. So poem is a totally surgical procedure. So it has a long steep curve, but once you do it and that horizon is widened and you can do so much procedures after that. Even the new procedure, Z poem and G poem, and there is a lot of scope. So it's a very interesting to watch Dr. Malhi doing it every day, almost once or twice a week. So it's a fantastic procedure.
Right.
Well said, Dr. Harpal. Okay, so if I may take some questions from the house.
Right.
One of our attendees is, is interested to know, although I think this has been covered, but maybe briefly, Dr. Malhi can explain it again. What is the pathophysiology of reflux? I believe he is talking about post-poem reflux. So if you can just briefly answer.
I think we have to understand the pathophysiology is different in Haller's myotomy, because if we talk about the anti-reflux barrier or LES, it has an intrinsic and an extrinsic component. So why reflux happens in poem is we are not touching the extrinsic component, which is the phrenoesophageal ligament and the angle of His. That does not get disrupted because we are not going that far. It is only the sling fibers or the oblique fibers of LES which are actually responsible for preventing reflux. If they get cut, which used to get cut because at that time the whole things were evolving at that point of time. I'm talking about 5, 7, or 8 years back. So, and we were doing more liberal gastric myotomies. So by now limiting the gastric myotomy to 2 centimeters and by saving those oblique or sling fibers, the chances of reflux are actually much lower now with poem compared to what it used to see maybe 5 or 7 years back. In Haller's myotomy, you'll be basically both extrinsic and intrinsic. So that is why you have to do a fundoplication in practically all people who undergo a Haller's myotomy.
Right. So I believe that answers Dr. Fadi's query. So the next question is from Dr. Roopjyoti, and he is interested to know what is the difference between the anterior approach and the posterior
Can I
approach.
make a comment, please?
Yes, Dr. Arpal, please.
So if you see the surgical part of when the Haller's myotomy was started, the surgeon used to start the myotomy onto the stomach because it is easy to start 3 or 4 centimeter onto the stomach and then go to the esophagus. So if you see the studies which had this lap Haller's myotomy, in that when the myotomy was 3 or 4 centimeter onto the stomach, the GERD was similar as we see in poem, like 40% or 50% cases, they had GERD. So if you stop at 2 centimeter while doing poem, the GERD will be quite less. So
Yes.
you have to stop there.
Yeah, Dr. Bhalla, can
Yeah.
I add?
Yes, please.
Yeah,
Please go ahead.
so whether we do Heller myotomy or we do the poem procedure, GERD is likely to occur in around 20-30% of patients. The reason is one is that we are doing the myotomy and we are reducing the basal LES pressure. The normal resting pressure of LES will come down. That will predispose to the reflux. Second, in Achalasia cardia, in addition to tight LES, there is loss of peristalsis of the esophagus. So whatever food, there is regurgitation. The esophagus, there is weak esophageal contraction. The esophagus cannot sweep it down. So whatever goes up, the esophagus is not able to push it back to the stomach. So that's the reason. Weak peristalsis and the low LES pressure after the myotomy, these are the reasons which occur after the poem or the LHM. So GERD is likely to occur 10 or 20%. So it's bound to occur.
Thank you, Dr. Vikas. Wonderfully explained, actually. So the next question is, this is from Dr. Gulaima. I hope I'm pronouncing the name properly. So he's interested to know, can we do a poem and a laparoscopic fundoplication at the same time?
So I'll take up, Bhavneet, both the questions. The previous you asked was anterior versus the posterior poem. No difference whatsoever. So the surgeons who got trained and started doing poem, learning the endoscopic skills, were more well-versed with the anterior approach. The gastroenterologist, endoscopist were actually more familiar with the posterior approach. So it is a personal choice. Both give equal results and both have same adverse effect profile. So it's one's choice, very little to choose between the two. As far as doing a poem and doing a laparoscopic fundoplication, yes, there is actually data which came almost 5 years back, where in the same sitting, in the same OT, after doing a poem, people were subjected to laparoscopic fundoplication also, and they can be done concomitantly.
Yeah, Dr. Malhi, do you think we need of doing poem and the fundoplication together? Because surgeon can easily do the myotomy along with the fundoplication. Actually,
what now we see even in our own clinical practice, if we look at our own patients, reflux has never been a major issue with us. So the symptomatic reflux which people come, so I think that number will be less than even 10%. So if we count in 200 odd patients we've done, not more than 10 to 15, I still remember, who had a reflux which necessitates regular PPI administration.
Yeah,
So
if you want to,
right.
If you want to do the laparoscopic fundoplication, it's better to do the laparoscopic myotomy along with the fundoplication. No need to add poem for the fundoplication.
But Dr. Malhi,
now we're talking about the hybrid procedure. So this could be one form of hybrid. If you want to club fundoplication, still yes, laparoscopic will still be a better approach.
Yeah.
But I believe this is doing a hybrid just for the sake of doing hybrid.
Yeah, I agree, sir. I agree. And
But
regarding
Dr. Malhi, I have a, please, Dr. Vikas, please go ahead.
Regarding anterior and posterior, sir, I think posterior one is easier. So when you have the endoscope, the accessories comes at around 5 o'clock, 5 to 7 o'clock position, comes in the lower part. So if you compare anterior, posterior is technically slightly easier. And on the anterior side, we have the cardiac chambers actually, and sometimes you have fear of seeing the heart. So posterior, I think, is for the beginner, posterior maybe safer than the anterior. But yes, if you want to add the poem F, if you want to do the poem with the fundoplication, then doing anterior becomes mandatory. You cannot do fundoplication with the posterior. Am I right, Dr. Malhi?
Yeah, perfectly right. Yes. If one needs to do a fundoplication at the same procedure, then you have to go at right at 12 o'clock and do an anterior approach. But on the contrary, if it's a post-Hallis myotomy patient who has come with a recurrence, you have to resort to a posterior approach only. So they're both sides.
So, Dr. Malhi, there's a query that although the clinical incidence of GERD post-POEM is in the range of 10 to 15%, but on
Yes.
pH monitoring, it was found to be quite higher in the range of 35 to 40%.
40%, yes.
So, although the patient may not be clinically symptomatic, but do these patients now require a surveillance, a long-term surveillance because of this subclinical reflux happening keeping in mind the various possibilities of Barrett's in the long term?
No.
Any thoughts or comments on that?
So yes, when we talk about this pH metry, initial studies which I've quoted, they actually did pH metry in almost all patients at 1 month, even at 3 months and 6 months. The largest data from US, once you follow up these people, there is physiological changes, the GI physiology alterations happen by which actually reflux goes down on a long term if you follow them, say at 1 year or even 2 years or beyond. So reflux never increases. Secondly, what reflux we were initially finding, it might not be true acid reflux. It could be non-acid reflux also. As Vikas alluded to in one of the comments, the food goes there, the food fermentation takes place. And then because of that also, so it has to be manually checked because any drop in pH, that software will take it as an acid reflux. But you will see how many times the pH has gone below 3. And now people are actually advocating that post-POEM, the criteria for an acid exposure time needs to be revised. And you need to do a pH metry or pH study not at 1 month, but maybe somewhere between 3 to 6 months. So this still is an evolving thing, and we need to see how. There have been anecdotal reports of even Barrett's at 10 years and one report of even at 7 years post-POEM, liberal gastric myotomy, reflux, but these are only anecdotal cases.
I think more than the pH, we should go by the endoscopy finding. If it's a grade C and grade D esophagitis, they are the patients who will require the long-term PPI.
Right.
So we are almost out of time. Any final comments from our panelists before we wind up?
I think Dr. Malhi has covered the topic beautifully, and there's nothing left for the discussion.
So the responses are already there in the chat box. Everybody is actually loving the presentation and how precisely and concisely you have dealt this topic.
And somebody wrote,
so
made easy to learn. I think Malhi made it very easy. Maybe Dr. Malhi can give a passing remark on the GPOEM also. A lot of patients are coming with the gastroparesis. Maybe he can give a passing remark.
Yeah, Dr. Malhi, just a parting comment on GParesis or GPOEM for the.
This is just the same extension of the third space procedures. So I think refractory gastroparesis, basically whether it's a diabetic population or it's an idiopathic or post-surgical. So that is one subgroup where it has actually been found to be extremely beneficial. So it's the same technique is same. So you do almost a tunneling in the antral region, almost start 5 to 6 centimeters proximal to pylorus, and you go till pylorus itself and do a myotomy till the pyloric rim. And this has again been shown to be wonderfully, has picked up very nicely in US, but we somehow in our practice are not finding that enough number of cases where we can subject them to GPOEM. But again, the future is with the GPOEM also.
We are actually overshot our time slot. So I think it's time to wind up now. I would like to thank all the panelists and our speaker, Dr. Malhi, for taking time out on a Sunday afternoon and sharing all their experience and about this interesting procedure. So thank you all very much. Thank you, Dr. Malhi, Dr. Vikas, Dr. Satpal, Dr. Harpal. Thank you for joining us, and thank you to all our attendees. And hope to meet all of you in person sometimes, or otherwise till our next webinar, which will be on in October, the first Sunday of October. So looking forward to all of you to seeing all of you in October again. And with this, I think we'll wind up the session now. Thank you so much once again. And
Thank you,
have a good
Bhavneet. Thank you, Vikas.
Pleasure, sir.
Dr.
Pleasure.
Satpal
It's
and
been a
Dr.
pleasure.
Pal.
Thank you, Ajit. Thank you, Ajit. Thank you. Very nice.
Thank you so much.
Sure.
Thank you.
Right.
Bye-bye.
Thank you and bye everyone. Dr. Harpa, please send us the invitation for the next webinar. Dr. Bhalla, please send us the.
Yes, definitely we'll do that.
Love to join that, sir.
Sure, sure.
Thank you, sir. Thank you.
October 1st
Thank
week
you
we
so
are
much.
conference there in Edinburgh. Hello.
Yes, Dr. Rujyoti.
Yeah, we are having a conference there in Edinburgh and
Yeah,
during October.
yeah.
And so we need to go ahead of time, well ahead of time.
Sure.
So
Kindly share the brochures. We will circulate it in our forums also.
okay, so nice of you. Thank you. Bye.
Bye, everybody.
Bye.
Thank you so much. Thank you so much. Bye-bye.